Well, thanks for your patience. I'm going to speak a bit at a detailed level on the treatment, use of antibiotics in the treatment and prevention of PANS and PANDAS. And I tried to download a cover shot of the part 3 of the series of articles that was published in the 2017 Journal of Child and Adolescent Psychopharmacology on treatment that was first authored by Michael Cooperstock. And PubMed doesn't seem to have that article easily available. So I have a hard copy from somewhere, but I didn't have a digital file. But that paper is well worth reading. Just as the immunomodulatory article was a very intensive writing experience, the treatment, the antibiotic treatment and assessment of infection in this population was remarkably intense. It went through somewhere between 27 and 30 drafts. And I've never participated in anything quite that rigid and intense and evidence-driven and rational and so on in my life. So we stand by what's in there. Pretty much everything that I say going forward is really what I do, not what I write or read. So I want you to know it's just my opinion, and I hope that Dr. Suedo and Dr. Cinnamon don't faint if they see anything that I put here. But I just want to stress that this is kind of what I do in the office so that you have a bit of a roadmap or a concrete setup to discuss with your own doctors. I don't have any new conflicts of interest, and I'd like to begin once again showing this slide that for me as an infectious disease doctor, there remains an uncertainty exactly where to draw the dotted line, who has PANDAS and who has PANS, because of the technical limitations in assessing the etiology of triggering infection in this population. And so a lot of what we do in the office from a therapeutic or preventative point of view is a little bit empiric. Actually, it's a lot empiric. And we move on if something is not working. I think in reality, it is common to be told to have parents report that some intervention we made with regard to antibiotic therapy was remarkably rapidly acting. In other words, even though I say I'm going to give you a month's trial or 6 weeks trial of X or Y, I often am told in retrospect that within 48 hours or 3 days that the child had marked clinical improvement, which kind of closes the feedback loop and supports the diagnosis, because we can extrapolate if that antibiotic worked, then we're likely dealing with strep or we're likely not dealing with strep. So the same problems that I talked about yesterday still exist, which is that diagnosing group A strep is actually challenging, even though it sounds like the easiest thing in the world. The microbial diagnosis is challenging. The serologic confirmation of diagnosis is full of limitations. And the treatments are imperfect. I think everything about PANS and PANDAS has that 1/3, 2/3 kind of response rate, and there's very few things that are 100%, which is always making things challenging. So I don't have any long, detailed case summaries, although it would have been interesting to put a few in, because it makes my day when I see a new patient and they've started on an antibiotic trial and they come into the office and they're back to themselves in remarkably rapid time. And I always say if naysayers would spend a day with me in the office, they would often see this kind of turnaround, and it's quite dramatic. This is a paragraph that was published in the American Heart Association practice guideline with regard to streptococcal infection. The PANDAS hypothesis has stimulated considerable research as well as considerable controversy. The current state of knowledge dictates that the concept of PANDAS should only be considered as a yet unproven hypothesis. Until carefully designed and well-controlled studies have established a causal relationship between PANDAS and group A strep infections, the committee does not recommend routine testing for group A strep, long-term antibiotic prophylaxis, or immunoregulatory therapy. In other words, go away. This makes it hard because the bias of this committee, as Dr. Suedo had alluded to earlier, is really a functional problem for us all. This is a paper that was just published within the last month, and I think it's striking. This is think the term is patient outcomes research. So this was simply a survey performed by these authors, I believe on a European population, and they simply asked the families to report on the responses of all the different treatments that they had been given. So this did not involve bringing the children back to the hospital or to the office for surveys to be completed or for clinical assessments or laboratory assessments. This was simply asking parents, what treatments did your child receive and how did they do? And you can see for each of many treatments listed here, there's a confirmed category and a suspected category. Since we're always living between those two lines, I don't worry too much about those differences. The black columns represent much improvement, and the white bars represent little or no effect. And as you can see, that children commonly receive multiple courses of antibiotic therapy, but the response to antibiotic therapy was over 50% and was pretty much the best thing on the slide. That use of a second agent at some point, without knowing the details of when and why second agents were chosen, also had benefit. And it was striking to see, in fact, that the use of nonsteroidal therapy, the use of CBT, the use of SSRIs were really given terrible scores. But it shows that every percentage point of response that we can get, regardless of where it comes from, is helpful, but that antibiotics really do have an important role to play in the long-term management here. So why isn't it 100%? Why is it only 55 or 60% at best? And the answer is that group A strep not only is it hard to diagnose, it's also surprisingly hard to treat. This is a remarkable paper that pulled together a bunch of old data, both from Europe and from the United States, looking at the failure rates of penicillin to treat group A strep pharyngitis. And you can see that, at least at the time of this paper being published, is a 50-year review, as you can see, a long-term analysis. And although back in the 50s, oral penicillin was remarkably effective at treating group A strep infection, by the turn of the century, the failure rates were approaching 40%. I haven't seen an updated slide that would take us out to 2015, but I have no reason to think that the numbers went down. And so the use of amoxicillin as a basic foundational agent to treat strep infections, to me, is problematic. This is a meta-analysis. You don't need to read the fine print. I'm sure most of you can't. What's important in a meta-analysis is that somebody downloads as many references as the medical literature can identify that address a certain problem. And so treatment protocols often have limitations in the number of patients enrolled, and so the statistics of efficacy become challenging because there aren't enough cases involved to get a statistically significant answer. Was that treatment helpful or not? So a meta-analysis pools all those references together and then asks, when you sum up, if the studies are sufficiently similar, you can just add them up as if it were one gigantic study. And then you have the numbers to do statistics. And so these are two columns that are separated by years, by decades or so, 1970, 1980s, year 1990 to 1999. And this column is defined by microbiologic cure. In other words, kids after treatment had a test of cure of throat swab. And this represented a column of clinical response. Families were interviewed and asked, did your child improve after treatment? And you see that in each study, there's a little mark where the statistics fall out for that particular study. On which side of the line is that little box? If it's to the left, then the treatment was not helpful. So little diamonds to the left favor penicillin therapy, diamonds to the right favor the use of a cephalosporin, which is typically cephalexin, but represents a sort of escalation in the intensity of the treatment for group A strep, because penicillin is labile to the enzymes that degrade it, and cephalosporins resist the chemical breakdown, the breaking open of the beta-lactam ring, and so they're more powerful and they're more stable in the oral environment. And as you can see, whether you look at it decade by decade or whether you look at it by microbiologic cure versus clinical cure, in all cases, the diamond is to the right of the zero line, favoring the use of cephalosporins to treat group A strep pharyngitis. Now, there are practices in this country, I can't say in this country because I actually don't know about Canada. There are practices in the United States where cephalosporins are given primarily for treating group A strep infection, but I can tell you in my part of the country, it's rarely done because New Englanders are just very conservative, and so penicillin worked 50 years ago. Why should we change? And so failure rates are common, and so kids, just as when they have ear infections and they get treated with amoxicillin and they fail and they come back and they're given a cephalosporin, so children with group A strep infection who fail treatment with penicillin or amoxicillin are given a course of a cephalosporin typically. So the reason to not move to cephalosporins universally is historically have related to issues of cost, because amoxicillin is inexpensive, cephalosporins are a bit more expensive, and also because of the impact on the human microbial ecology. Cephalosporins kill more germs than amoxicillin, so penicillin and amoxicillin are more of a surgical strike against the group A strep, and cephalosporins are more of a shotgun. And we worry more about the effect on the gut microbiome now than we did in the past. But on the other hand, we have a child with a sore throat, at least, who's suffering, and we'd like to get rid of the infection. And so I sometimes think we bend over too far backwards, worrying about the downstream impact of antibiotic use for cephalosporin. And I have come to the point, at least among the children whom I see, I don't use a lot of amoxicillin. And I have to say that many children are referred to me. By the time they get into my office, they've been given amoxicillin and they've done well. And I don't want you to think the drug is ineffective, but it's in starting a new course of treatment in a complicated child, I tend to reach for cephalosporin therapy. People say, well, what about the other drugs? And remember that a certain percentage of children will be allergic to amoxicillin. They may be allergic to cephalexin. And so one has to have in one's armamentarium other agents. And the problem is that the other agents are losing their efficacy as well. And this demonstrates that erythromycin, which has essentially identical spectrum of coverage as azithromycin, and clindamycin as well, are both only about 85% efficacious in terms of the streps that they encounter, meaning you are buying into a failure rate of 1 in 6 right from the get-go. And azithromycin has certain favorable features I'll talk about in a moment. And clindamycin, on the basis of a couple of very, very small clinical studies, was given the reputation that it eradicates group A strep from the pharynx better than any other antibiotic agent. It was based on fewer than 24 kids, as I recall. And to have that sort of shift practice for millions of children always struck me as just amazing. But it turns out I don't think it's particularly effective that way. And I primarily use clindamycin when children are allergic to penicillins and have failed a trial of azithromycin therapy. This data is relatively recent. It's just a few years old, but it's very location dependent. There was a paper published in the New England Journal of Medicine a decade or two ago that in the Pittsburgh, Pennsylvania area, for a given winter, 50% of group A streps were resistant to erythromycin. And so if you're allergic to amoxicillin and you don't even bother to take erythromycin because there's a 50-50 chance of success or failure, and so those children had a high rate of receiving clindamycin. Now, for the people in the audience who think about these details, erythromycin and clindamycin work in almost exactly the same spot, and we'll talk about that in a moment. But they have an overlapping binding site on the protein synthetic mechanism of the bacterial cell. And even though the two drugs are of different chemical families, and we think of them sort of in separate lines on some big table, resistance to erythromycin and resistance to clindamycin actually overlap tremendously. And so it's not surprising, really, that group A strep isolates that are erythromycin resistant have a high rate of being clindamycin resistant as well, although you can certainly find strains that are sensitive to one and resistant to the other, and vice versa. We've talked about how amoxicillin failures are distressingly high. And if you're a primary care pediatrician in a busy practice, you're happy to give amoxicillin as a first course and shrug your shoulders and say, well, let's see what happens. But by the time children are having any kind of secondary complications, such as pandas, it's not an acceptable choice for me, and I mostly use cephalosporins. It turns out that the environment of the group A strep in the throat is very complicated. We've been using the words sewer and cesspool a lot up here for the last day or two, and it's totally true. And so there are both good bacteria that inhibit the growth of group A strep, and there are bad bacteria that promote the growth of group A strep by degrading the antibiotics used to treat the strep infection. This is this fellow Yitzhak Brook has made his career being able to grow germs without oxygen. The environment of the tonsils has a very low oxygen tension because of the crypts, the folds of the tonsillar surface, and the average lab is not very good at recovering those and getting them to grow, and he's made it a specialty. So he's published paper after paper basically getting swabs from different parts of the body, growing the anaerobic bacteria well, and then saying this is what we found in this spot and this spot. So he's turned his attention to tonsils. And if you just look at this paper and ask about the good bacteria that are known to inhibit the growth of group A strep, these are called interfering strains. You can see, without worrying too much about the names of the strains or which ones are aerobic, meaning they grow in oxygen, and which ones are anaerobic and don't grow in oxygen, the details aren't important. What's important is that among children who were free of group A strep, they had, as you can see, a number of strains of bacteria that inhibit the growth of group A strep. The group A strep children, the ones who are carrying group A strep, had fewer of these inhibitory bacteria. And we tend to think of this, there's a term that infectious disease doctors use called colonization resistance, where if you have good bacteria living on the surface of a space, the bad bacteria have no room to grow. And antibiotics are kind of like a neutron bomb. They clear out the good bacteria, they vacate the space, and then the pathogens can grow in greater number. So after being treated with penicillin, you can see that the patients who are already carrying group A strep have even fewer of those good inhibiting bacteria. So that we wipe out the good bacteria with antibiotics, and if we don't wipe out strep at the same time, we're in trouble because now the strep grow even more. But what's probably more important is that there are strains that produce this enzyme called beta-lactamase. This is an enzyme, that degrades the antibiotics in the beta-lactam family. And here you can see that the presence of some of these strains that express this degrading enzyme are of low frequency in healthy children, and after being treated with penicillin, they increase in number and make it more likely that the group A strep will persist and grow because the antibiotics have been degraded. And this is why the use of amoxicillin is thought to be problematic. The group A strep isolates themselves remain exquisitely susceptible to penicillin and amoxicillin in the test tube, just as they were when penicillin was discovered nearly a century ago. It's just that the environment has changed. All these other germs now do the work of degrading the drug and making the strep functionally resistant. So I don't want to be redundant, but as a summary of my philosophies, I don't use much amoxicillin in this population, although when kids come in and are doing well, particularly children with mild symptoms, children who've had mild OCD and manageable tics who are given amoxicillin in the pediatrician's office and come to see me a few weeks later and they're doing well, I don't suddenly say you need a big gun antibiotic. But if kids come to me and they're not doing well, I tend to move on. So in established cases, I almost always use a cephalosporin as my initial therapy, and I've listed the details here in terms of the doses that I typically pick. I try to give it twice a day. It's been shown that that's sufficient. We used to think you had to have antibiotics in your bloodstream all the time, which is why penicillin years ago was given 4 times a day to treat strep. I should ask for a show of hands, how many people actually took all the doses of group A strep therapy for 10 days? Because when I had a strep throat infection as an adult, I was shocked at how many tablets were left in the bottle at the end of 10 days. And that's me. And so twice-a-day therapy has a higher compliance rate. The only downside is if you assume imperfect compliance and you drop that number down by one or so, you're down to once a day, and it's almost always ineffective. I will say that among the children I treat in the office, I know the compliance is virtually perfect, because this is not just the kids with sore throats, and when their sore throat gets better after a day or two, the parents stop worrying about getting every dose in. These are PANDAS parents. They do their stuff, and they make sure that their children get their therapy twice a day. This avoids the need for the nurse at school to have a bottle of suspension therapy and for the child to be called out to the office to get medication. This has really been studied rather extensively with other upper respiratory infections like otitis media, that limited dosing per day is sufficient, and the general world of beta-lactam therapy is moving to twice-a-day therapy almost exclusively. There's actually a once-a-day formulation of Augmentin to take, which I've tended to stay away from. I think you need a wheelbarrow to kind of get the pill home. So even though group A strep therapy is traditionally 10 days, that was shown to be sufficient to prevent the development of acute rheumatic fever. I tend to treat longer because I've just anecdotally have noticed and been informed of a high rate of relapse after 10 days of therapy. And so I think of it as kind of a seamless transition from therapeutic antibiotic administration to prophylactic or suppressive antibiotic administration, and the initial prophylactic dose, just by coincidence, happens to be the same as the treatment dose. So it's easy to just write a prescription for a month and make it renewable, and then gradually wean the dose down depending on how kids go. So I alluded to the fact that even with cephalosporins, there are failures. We know that the compliance is excellent among these children because of the efforts of the parents. And it comes down to whether there's deep infection in the tonsils. Ear, nose, and throat surgeons commonly tell me that they take out tonsils of a PANDAS child usually for standard indications, but they cut the tonsil open and they culture the insides just for curiosity, and it's not unusual to grow group A strep in that situation. So they're protected sites somehow within the tonsil. This is an area that hasn't been studied very well. Our colleague Beth Latimer has a lot of experience with tonsillectomy, but I just don't have the microbiologic data that accompanies all of her surgeries to answer that question. The possibility of intracellular infection, where the strep penetrate through the membrane, as I displayed yesterday, is also a possibility for which we don't have very good data or definitive data. Now, what happens when kids fail? So if children are on effective suppressive therapy, unfortunately, it's not unusual for me to get a phone call that a child has either gone off the rails or has a new sore throat, and I say, you have to go to the pediatrician and you have to get a repeat throat swab. And the frequency of kind of pure behavioral or psychiatric flares without any sore throat symptoms or any findings in the pharynx of these children is not unusual. And I always get a phone call from the pediatrician's office. You wouldn't believe it, that culture was positive. And the next line is always, but he's already on sort of traditional high-dose cephalexin therapy. What are we going to do next? And I generally administer amoxicillin clavulanic acid. This is a combination agent that starts with amoxicillin and has clavulanic acid built into it. I bet everybody in the room knows as much about this as I do. That's the equivalent of my walking down a dark alley by myself, or else walking down a dark alley with Shaquille O'Neal or LeBron James or someone, and suddenly I get respect. So the clavulanic acid prevents the degradation of amoxicillin, so it's called a beta-lactamase inhibitor. It has very little antibiotic activity of its own, but it prevents the breakdown of the drug we want, and it's made a simple drug like amoxicillin become a potent broad-spectrum agent. And in fact, the use of beta-lactam and beta-lactamase inhibitors is a whole new domain in antibiotic therapy and antibiotic development. And it has allowed us to develop agents that treat highly resistant hospital, multiple drug-resistant kinds of pathogens. So we either consider higher dose cephalexin, and I'll go up to, this is basically a full adult dose even for children, or use adult doses of amoxicillin clavulanic acid. what follows is really how well do the kids tolerate it. Some kids may be allergic. The allergies tend not to be dose dependent, so if a child's tolerated a lower dose of cephalexin, it's doubtful that one will see a rash just as the dose is being increased. But these kids have a lot of sensory issues, and the taste of high-dose Keflex may not be satisfactory. The taste of amoxicillin clavulanic acid is definitely not satisfactory. Some of these drugs produce GI distress. They may produce diarrhea. And it just comes down to what can we get in consistently without spending hours a day chasing kids around the house giving antibiotics. I've listed management when kids do have a history of drug allergy. If they have a rash reaction that is not hives, not urticaria, you can usually switch from amoxicillin-based therapy to a cephalosporin, and conversely, if they've been on a cephalosporin, you could switch back to amoxicillin clavulanic acid. If someone has a true hive reaction and they fail to improve with one of the alternate agents like azithromycin or clindamycin, they really need to get an allergy test done. Many older children, sort of grade 4, 5, 6, who have a history of bona fide hives in childhood when treated for an ear infection, have outgrown that reaction, and it's safe to treat with amoxicillin clavulanic acid. You just have to demonstrate that it's safe, and the allergists now have the tools to do screening skin tests and then just do oral challenges. Kids come in to the office, they're given 1/10 of the normal dose, and if an hour later they're okay, they're given the rest of it, and if an hour later they're okay, you're good to go. You'll be reassured, I suppose, to know that at least around where I practice, it's just as difficult to get an allergist to see a child as I'm sure it is for you up here. There are long delays, but it's very important information to glean, particularly for these complicated kids, and it's worth having the pediatrician try to intercede and have a kid seen urgently, or at least in accelerated, expedited fashion. I generally keep away from the fancier cephalosporins. They're quite costly. The doses, ironically, on a milligram per kilogram basis, on a weight basis, are very low. The drugs were developed typically to treat urinary infections, for which low doses are sufficient because 100% of the dose comes out in the urine. They get FDA approval, and now they're being used for other indications, but the dose never increases. And I would feel more comfortable giving high-dose older cephalosporins than giving these piddling doses of newer cephalosporins that are more expensive and also don't taste very good. But again, if a child is doing reasonably well on one of these agents, I don't necessarily switch them off. Managing an acute PANS flare is a challenge because of the diagnostic uncertainty. Might this be a sort of hidden case of strep-related disease of pandas? And so are they really pandas kids with non-diagnostic testing, or do they truly have an illness triggered by a different pathogen? So I have generally, for children who come to me antibiotic naive, I've given them a trial of a cephalosporin to see, well, do they get better with pandas treatment? And the answer is many of them do. It's hard to incriminate mycoplasma or any other atypical cause of this infection if they get better with an antibiotic that's pointed directly at strep. On the other hand, I don't flog this for months and months of treatment. If they don't improve within, say, 4 weeks or something like that, I would just say it's not pandas, it's PANS. We're happy to offer a trial of azithromycin. But remember that azithromycin is a great all-purpose drug, but it's not perfect in any particular direction. It has a measurable failure rate against group A strep. It has a measurable failure rate against Mycoplasma pneumoniae as well. It's just that because we can't grow that pathogen very well, we can't get good numbers on its failure rate. But among clinicians, failures of azithromycin therapy are not at all unusual. For the older children, we can give doxycycline. If they tolerate it, that's great. If they don't tolerate it, it's not going to be useful. Remember that doxycycline not only provokes GI upset and is frequently taken with meals, but it produces photosensitivity. For those of you of a certain age, you may recall seeing people at the beach using those aluminum reflectors so they can get twice as sunburned in half the time. That's what doxycycline is, like that aluminum reflective foil, because the drug is in the bloodstream, the ultraviolet energy sunburns the skin from above, but it reaches the superficial blood vessels. Doxycycline is photoactivatable, and it retains that ultraviolet energy, and then when it releases it, you get sunburn from the inside. And I've seen people take cat naps for 10 minutes and wake up blistered from doxycycline. It's not an allergy, it's a photosensitivity. So it's a great drug in the winter, particularly in a place like Saskatoon. But imagine treating children with doxycycline who have Lyme disease in New England down at Cape Cod for the summer, and they're outdoors all day in t-shirts and shorts or less. It's a very challenging drug to use. So it has its place, but it's very difficult to use in the summer. So prophylaxis against group A strep. Using the acute rheumatic fever as our historical base. I showed these slides briefly yesterday. Long-term prophylaxis is mainstream care. And this is the standard of care against rheumatic fever. And you see there are long intervals of time, a minimum of 10 years or 40 years if someone actually had carditis, but typically at least until adulthood. So the establishment is comfortable with prolonged therapy against group A strep when dealing with the concern about recurrent acute rheumatic fever. I've listed the doses of penicillin for the prevention of acute rheumatic fever, and from the place where I stand, these are very, very low doses. You saw the doses of cephalexin that I mentioned before. 600,000 units translates into 375 milligrams of penicillin. And so when someone's getting 600,000 units of injectable penicillin, that's 375 milligrams every 3 weeks. I'm not sure that's all that much different from opening a vial and just sniffing the penicillin. I say that, and yet historically it's worked. And so, there's this philosophy, if it ain't broke, don't fix it. And I think we have all encountered little mini outbreaks, little mini epidemics of acute rheumatic fever in the United States, and I have no reason to doubt that it's happening up here as well. And it just gives pause to say that maybe these children should be getting cephalosporins for their long-term prophylaxis as well. But I don't have the evidence to go before these large academic committees to say that I think their therapy is about 40 years out of date. This is some work that Dr. Suedo has recently published demonstrating that antibiotics are a mainstay not just in the acute management and early stage management of these children, but through the remainder of their childhood and into young adulthood, antibiotics remain a foundational part of their therapy. The problem in trying to address the role of preventative antibiotic therapy in this population for this condition is very, very difficult. The concept of any relapsing, remitting disease means whatever you do by way of prevention, you have to do for a long time, because otherwise the ups and downs of the illness are going to just create so much noise that it's hard to assess whether your intervention was helpful or not. Remembering that viral disease, like any inflammatory signal, can trigger a flare of PANS or PANDAS that has nothing to do with streptococcal infection or mycoplasma infection and may not have anything to do with antibiotic treatment at all, means that you may have apparent failures of prevention that have nothing to do with what your preventing therapy is targeting. And it's just unfortunate sort of background fluctuation. These create real problems for trial design and for study analysis, because you need to have a large enough trial to get data that's believable. Publishing a dozen or 2 dozen kids for short periods of time may be tantalizing and give data that supports a larger trial, but it rarely answers any questions. And you also have to plan the trial to coincide with when group A strep is. You can picture a 6-month trial starting on May 1st and ending in November, when the annual seasonal variation of group A strep means you've given prevention during the low ebb phase of the epidemiologic cycling. So it's not likely to have the same outcome as if you gave it from November to May when group A strep is on the rise. And finally, when you are performing trials of this sort, there's always bleeding between the two groups. And so there are control patients who are given antibiotics, whether for an unrelated reason, like a skin infection or an ear infection, or there are children who are in the treatment arm and they stop taking the medicine. It makes the numbers less robust than they might seem. But that said, there is a sense that antibiotic prevention is helpful going forward. This is more work that Dr. Sweeto has published. There's a theme here. But it shows that the administration of either penicillin or azithromycin, this is a little over 10 years ago, but even so, showed that the number of streptococcal infections basically was virtually eliminated by the use of preventative antibiotics. This was a 12-month trial, so it included both the seasonal peak and the seasonal low of strep infection. And the same was true for Pandas flares. As you can see, the numbers went down considerably. So these were 23 patients, and yet the data was quite dramatic. 248 patients were screened, meaning 10 kids were screened, more than 10 children were screened for every patient admitted to the trial. This is an inherent challenge of all of these studies. And it makes the IVIG trial, where 1,100 plus children were screened to enroll 35-ish kids or so. It just points out the difficulty of doing clinical research in this population. There was no placebo control in this study, but that worries me less, I think, knowing that every year there's group A strep out there. But critics will say, but there was no placebo. And we've talked about the seasonal variation. A trial of once-weekly azithromycin was done. This was a terrible study. It was a heterogeneous population of patients, and it didn't appear to be effective. But I think once-weekly azithromycin is kind of like 375 milligrams of penicillin every 3 weeks. I don't think of it as very intensive therapy. Tanya Murphy studied daily azithromycin therapy, actually high-dose daily azithromycin therapy. And as you can see, once again, a relatively limited number of children were enrolled in the study. And she gave 10 milligrams per kilogram per day, which is what defines high-dose therapy to me, with a limit of the standard high-dose adult dose. This is for those of you who have taken a Z-Pak. 500 milligrams is the first day's treatment. That's the kind of up-and-running dose. And it seemed to be helpful. The azithromycin group, there were close to 50% of children who responded versus fewer than 10% in the placebo group. This is responded on the basis of the CGI scale. The OCD scale, the CY box scale, was not statistically significant. But in fact, if you look at the numbers, there was a hint that it might have been helpful, just that the numbers were not great enough to get statistically significant data. There was some effect on the electrocardiogram, as we saw before. These drugs do that. And the key thing is that you can't give too many of these drugs simultaneously. So the use of azithromycin is heavily regulated, so to speak, by the concurrent administration, particularly of SSRIs. And for some of the children with severe nausea and vomiting phobias, the use of ondansetron in that situation. So the azithromycin at that dose sometimes has GI symptomatology, abdominal pain, diarrhea as well. And this is the figure of her study. This reflected the CGI scale, the global scale, and showed that azithromycin, the kids seemed to do better over time than the kids in the placebo group. Ideally, this study would have been carried on for a year with more children, but that's really a lot of work. It's beyond the easy scale of a single center doing a single investigator-driven research project. So this requires coordination at a larger level, and these are hard to arrange when the funding agencies have a kind of bias against PANS and PANDAS to start out with. So antibiotic prophylaxis against group A strep in this population, I've already made it clear what I think about the AHA recommendations. This is low-dose therapy. Now, I think it looks good still for prevention of acute rheumatic fever, simply because the incidence of acute rheumatic fever is so low that failure rates of amoxicillin just don't hit the radar. If there were more acute rheumatic fever out there, I think we would see more failures, to tell you the truth. But if children are on this low-dose therapy and have a breakthrough episode, I switch them to cephalosporin at a dose range that's pretty comparable to treatment doses, aiming at the lower dose if they're doing okay, and at the higher dose for more severely afflicted kids. And as I've stressed, I always try to get diagnostic cultures done if there's a change in circumstance. And that acute behavioral flares while receiving suppressive therapy is by no means unknown. And I probably every other month or so, another patient of mine has a positive throat swab, despite being on really strong doses of suppressive therapy. What do I do if they have a breakthrough episode with suppressive therapy? I increase the dose, or I switch to amoxicillin clavulanic acid with hopes of weaning that over time. How long does one give preventative therapy? Again, it just sort of depends. I think of it in part as a function of the age of the kids, the duration of their prior illness, their risk of group A strep exposure, and the severity of their symptoms. So if they're older kids in whom hitting that moderate to severe category means school absence, and they get behind in their classes, it's now a new problem superimposed on the existing troubles, I tend to treat more aggressively with suppressive therapy, remembering that younger kids are the ones who have the highest risk of group A strep exposure. The incidence of group A strep pharyngitis declines as you get older. Unfortunately, you have to really get old, that is out of high school, to see the rate really decline. And for people over the age of 45, they hardly ever get group A strep pharyngitis. For patients who do well during that first year of my care, I often try to give them an antibiotic holiday that summer. This is not standard acute rheumatic fever prophylaxis approach, but I've gotten away with it much of the time. Parents appreciate having a break because they're concerned about long-term antibiotic therapy. And in general, it's a time of low group A strep exposure risk, so that you're not really gambling very much. It's not like taking a break in January, which I think would be a stressful time. If a child does well in the summer, what do you do in the fall? And that also depends. And it depends. Sometimes I'm recommending restarting antibiotics, and the parents say, no way, Sarah's doing great, we're just going to go with the flow. Other times, they say, Sarah's doing great, but no way do we want to go back to where we were last year. Let's restart antibiotics on the first day of school. And sometimes you say, let's see how it goes, and we can restart antibiotics in the fall if we need to. And I have had the entire range of familial responses. There's a college student who still comes to see me once a year who had his last symptom about 5 years ago. His dad comes in and quite frankly says, I will not stop antibiotic therapy. If you won't prescribe it, we'll find someone who will. But he said, this is a quote, he said, I have PTSD from my son's experience, and if the acute rheumatic fever kids are treated till age 21, well, darn it, you're going to treat my son till he's 21 as well. And if you won't do it, no problem, we'll find someone who will. So his child is truly asymptomatic and has been so for years, and I would have said he's one of the children who's outgrown the problem. But the families have a big voice in this because they're the ones actually giving the therapy or not giving the therapy. So with older kids, I also try to get them off therapy. Depending on how bad their symptoms are and how high their dose of antibiotics might have been, I might just have the dose of treatment during the summer, that first summer, and maybe just continue that half dose of treatment for the coming school year, and then the following spring try to stop therapy altogether. The problem that's challenging is that kids will have symptom flares that ultimately turn out to have nothing to do with strep. And it makes me look bad if I stop therapy and then they get enterovirus in the summertime and they have a symptom flare, and the parents say you shouldn't have stopped treatment. Of course, enterovirus has nothing to do with antibiotic suppression, so it's sort of problematic in that way. But we try our best, and I try to stop antibiotics when I can. Now, the use of antibiotics in PANS does not carry quite the same long-term obligation, because whereas group A strep is always around, children don't get mycoplasma pneumonia or other of the common atypical respiratory pathogens over and over again. They're just not at risk. Relapsing or recurrent mycoplasma infection is known to occur, but it's infrequent, probably fewer than 10% of the time. And so when I give azithromycin therapy to treat mycoplasma pneumonia, I treat for a while, and I think Dr. Cooperstock and I kind of duked it out, and 3 months or so of treatment seems like a reasonable course of treatment. And so when we have no need of open-ended azithromycin prophylaxis because the exposure risk is for the mycoplasma germ is just not an ongoing, continuing problem. To the extent that azithromycin will prevent group A strep infection, there's certainly benefit there. But this is something that we have to kind of work our way through. But azithromycin, because of the EKG effect, the fact that there may be other drugs involved in the medical management that may have QT interval effects, makes everyone happier to stop azithromycin sooner rather than later. One thing that has caught the attention of the medical community is that antibiotics may be helpful for reasons totally unrelated to their antibacterial or their antimicrobial effects. And it turns out that many, many antibiotics have anti-inflammatory or other unique properties, and we may be fooling ourselves to think that we're doing a great job suppressing infection. We may be doing a great job providing additive anti-inflammatory therapy. And I'll show you a couple of examples of that. So beta-lactams, the penicillins and the cephalosporins, are thought to have an anti-inflammatory effect, as well as drugs like azithromycin, which turn out to be, at least in studied examples, highly immunomodulatory agents. So I don't want to make this slide more complicated than necessary, but neurons are damaged when they are stimulated too greatly. It's called excitotoxicity, and some neurons release glutamate as the neural transmitter, and there's so much glutamate around that it kills the neuron. So the neurons have an escape valve called the glutamate transporter that sucks the glutamate back in and reduces the toxicity to the next neuron. And it turns out that antibiotics promote the production of this salvage pathway and lower the levels of glutamate in these excitatory networks. And you can see that at what are largely clinically achievable doses of antibiotics administered, that you can increase the production of this salvage enzyme enormously. And this was thought to be so promising that it was actually trialed not only in mice with ALS, but it was actually, there was a human trial of ceftriaxone therapy, antibiotic therapy to treat Lou Gehrig's disease, amyotrophic lateral sclerosis. It turned out not to work in the human trial, but the notion that antibiotics have effects far beyond their antimicrobial effect is a real concept. Azithromycin has a different chemical structure, a different locus of activity. It binds to the protein synthesis machinery of the bacterium and prevents the growing protein chain from growing. It has other effects. Bacteria actually live in communities. The bacteria know when they're surrounded by like. It's called quorum sensing. There are certain proteins that are made that the other bacteria all make, and when the level of this protein in the environment is high enough, they realize they have a critical mass, and they start to make toxins and do bad things. And they shift from a growth mode to an invasive mode. They make biofilm that coats the surface and sort of traps the bacteria beyond the reach of our bodies to fight back. And so it's a drug that has multiple properties. It also has a huge effect on inflammatory cytokines. These are the immunomodulatory substances released by lymphocytes and inflammatory cells to communicate with each other. It tips the immune response from an inflammatory pathway to a non-inflammatory pathway, Th2 cells. It downregulates the expression of certain inflammatory receptors on the surface of cells, and is supposed to, depending on the stage of infection, augment white cell killing of bacteria or suppress white cell function, which is actually desirable because when white cells engulf bacteria, they release some of their degradative enzymes into the environment, which is toxic and damaging to the tissue. And this is a schematic that I found that may or may not be readable from where you are. It's not readable from where I am either. But it demonstrates that there are effects of azithromycin on bacteria, on eosinophils, one form of inflammatory white blood cell, on neutrophils. These are the main inflammatory white cells that eat and kill bacteria. It affects the epithelial cells, particularly the lining of the airways, and has a variety of effects that may be clinically important. To put some weight to this, as opposed to just some theoretical discussion, azithromycin is given commonly to inflammatory lung disease patients, regardless of what germs they may or may not have contributing to their infection, purely for the anti-inflammatory benefit of azithromycin. There are compounds being developed that are analogs of azithromycin that have lost all antibiotic effect, but they have more of an anti-inflammatory effect than azithromycin. So they will be pure non-steroidal, non-steroidal anti-inflammatory agents. But this is an area that's very young, but it's intellectually and conceptually very important. And the hope is that we will be able to dissect apart the anti-inflammatory benefits of the drugs we use from the anti-bacterial effects of the drugs we use, and have a scheme for treating and going forward. So a few final thoughts. Again, as someone who crosses paths with children who have seen some of the Lyme specialists in our part of the country, there's a mantra that more is better. And I think the record for number of concurrent antibiotics given to a single child for suspected Lyme disease, in my experience, was 6. So this child came in, had a central line to get intravenous ceftriaxone, was on 5 additional antibiotic agents. And like the light bulb never went off that maybe this isn't a good idea. In terms of just allergy, if a child develops a rash, which of the 6 agents is the culprit? You now take 6 classes of drugs off this child's potential list of medications, not to mention all the other side effects that might occur. I mention this simply because some practitioners send children to me who are on high-dose amoxicillin clavulanic acid and high-dose azithromycin or high-dose clindamycin, and of all the antibiotic toxicities that we confront every day, bacterial superinfection by this intestinal pathogen called Clostridium difficile or C. difficile is something that adult practitioners deal with every day. Patients get a single dose of clindamycin for dental work and they get C. difficile infection that's refractory to treatment. It doesn't take much antibiotic therapy in adults to disturb the intestinal microbiome, the bacterial flora of the gut, and allow this particular pathogen to overgrow and produce intestinal illness that can actually be life-threatening. Through one of the few good things about PANS and PANDAS, children given chronic antibiotic therapy for this condition rarely get C. diff. And I don't want to jinx myself, I'll just tap the table lightly, but I don't think I have provoked C. diff superinfection in any of the children I've treated primarily. The only kids I've seen with C. diff infection have come to me having received concurrent multiple antibiotic agents for long periods of time. And I can tell you that the presence of C. diff and the need for continued antibiotic therapy against the germs you're really interested in is a disaster, because the use of continued cephalexin or continued amoxicillin or continued amoxiclavulanic acid is killing off all the good bacteria, and that same colonization resistance that protects us against C. diff in the first place now allows the C. diff to grow. So you have to give another agent to treat the C. diff, and you basically can't eradicate it until you stop antibiotic therapy for the PANS or PANDAS, which is obviously a challenge. So I live in dread of C. diff superinfection among my kids, and when parents call me to say, oh, they've gotten diarrhea from this agent or that agent, I like to get them tested because I need to know. It's really important, because throwing more antibiotics at them may make the C. diff worse. So I try to avoid multiple agents simultaneously for that reason. I would say if there were guidelines for some of these fine point details, they would have been in the published guidelines. Not only was there not necessarily consensus, but there was no published database to address some of these seemingly small point but clinically very important issues. So I'm going to stop, and I gather there'll be plenty of time for questioning when we get to it.
Thank you very much for that.